Hello, everybody, and welcome to the Better You podcast. I have with me Dr. Tracy Tilton, Robbie Patani, and Ali Bailey, and we're going to be talking about schizophrenia. And I'm really excited because I really don't know anything about schizophrenia except for Fight Club, which I'm positive is wrong. So I'll pass it over to Tracy to kind of fill us in on this.
Okay. Well, schizophrenia is a very complex and chronic mental illness. Um, it's defined by major impairments in mental, emotional, social functioning. So there are what we call positive symptoms, which are things that aren't supposed to be happening but are there, like delusions, hallucinations, disorganized speech, disorganized behavior, which I'm going to get into more detail about those. And but then there's negative symptoms as well, and those are things that those are deficits. So they are lack of movement. We call them the 5 A's. There's avolition, which is like lack of motivation, flat affect, alogia, which is deficit of speech. What are the other ones? Oh, anhedonia, which you lose pleasure in doing things that you used to find pleasure in, and attention, impaired attention. So, like for instance, an example of avolition would be it's just like you don't participate in goal directed activities anymore. Like maybe, I worked with a lot of people who had schizophrenia on an inpatient unit, and we'd say like, okay, why don't you do this today? Like, do you want to go to art class? Why don't you, go get your stuff and do that? And they sit there and they like just can't. They'll be like, okay, but like nothing happens, and they do that towards many specific goals they would have for like behavior, but they like can't seem to motivate to do those, not out of like laziness, but because of lack of certain chemicals.
So I guess my question on that is in terms of the negative aspects of it, what separates schizophrenia from bipolarism? Because a lot of what you're describing to me, and again, I don't know anything, but sounds like the depressive episodes of bipolarism in terms of the negative symptoms.
Well, they're somewhat similar, but these are much more severe. I mean, not
Oh,
that there are people who have depression who like never get out of bed and stop doing hygiene and just never go anywhere, things like that. Absolutely, that happens. This is it's different because they're somewhat similar, but these are much more severe. I mean, not
oh,
that there are people who have depression who like never get out of bed and stop doing hygiene and just never go anywhere, things like that. Absolutely, that happens. This is it's different because it's in addition to the positive symptoms. So you don't have just the negative symptoms. You have both. So there's also cognitive symptoms, which are deficits in your like working memory, your executive functioning, like concentration, attention, working memory. Those also are impacted by schizophrenia. The course of schizophrenia is typically chronic, and only 20% of people who have it report good treatment outcomes. It's a very debilitating, debilitating disorder. Um, there are, you must be on medication for treatment. It's treatable, but it's never like really resolved. It's crucial to be on medication, stay on the medication. I'm going to go into the different meds, a little later, but um, you every time you go off your meds, it increases the likelihood that it will become more severe. Like if you go off on, and if you're off them longer and longer and longer each time, it's really bad for the course of the disorder. And a lot of people who take
oh, that is terrifying.
schizophrenia go
Uh,
off the meds for different reasons. Go ahead.
um, Sorry, so like this is a forever thing. Like if you're schizophrenic forever. There's not like I know um anxiety, depression, you know, to an extent bipolarism. I know that stress can kind of induce those or make those significantly worse if
Yeah,
you're doing it. But for schizophrenia, like you're schizophrenic, and
yeah.
that's it.
Once you
Full
have
stop.
it, you
Done.
have it. And it doesn't wax and wane. I mean, you could be in like, we don't call it down because it doesn't completely go away, but you can maybe have a lessening of some of the symptoms. So maybe, I mean, they pretty much always have flat affect. Like there's just nothing, no expression whatsoever. And they'll kind of, sometimes they do this like shuffle when they walk, especially if they have tardive dyskinesia from some of the medications, which is a medication induced movement disorder, where you kind of like move your mouth a lot. Sometimes your tongue protrudes. You have this little shuffle, like your arms just hang at your side. And it's usually, you get it from taking antipsychotic medications, and you can sometimes then reduce or change the dosage, but it usually just comes back, and a lot of times it's permanent. So that's unfortunate.
I mean, just like Aaron, I don't know too much about schizophrenia as well, but like, is there a range when a human being like experiences this, and like, is it prominent more in men or women?
There's no difference between the sexes.
Okay.
But there are with men sometimes. They have more negative symptoms versus positive symptoms, but you have to still have the positive symptoms to be diagnosed with it.
Okay.
You have to have symptoms must be present for at least 6 months, and they would be like delusions, hallucinations, disorganized speech, disorganized behavior, catatonic behavior, negative symptoms. So I'll go over some of the different types of hallucinations. So there's auditory.
Sorry, Tracy. Like, what about the age group? Like, when does the diagnosing starts, if anything?
Oh yeah, it's from for men it's late adolescent to early adulthood, and women it's early 20s to late 20s. Like there's kind of a bimodal. You get it. There's two different times for one. I'm trying to say it's bimodal with women and it's not with men. So there's auditory hallucinations. Usually they're like commanding the person to do something. They're criticizing them. They're insulting them. They're telling them, like, if they're commanding, like they say, like, go kill this person, or, go do this, like negative things. It's not like, go garden. It's like negative things. Absolutely.
So,
yeah.
Pardon my usage of inappropriate terms, because I just don't know the right terms to use. But like as you're describing this to me, what I'm hearing and what I'm imagining is kind of like the classic like 1960s version of like these are the people in asylums.
Right. Like just
And
sitting
like
there, like with a lot of
this
medication.
is what we used to classically call crazy people.
Right.
Again, I know that's an inappropriate term, but
That's the
like
thing.
this is just kind of how I'm imagining it is like that's what this was.
Yeah, and that's a fairly accurate interpretation, depending if they're getting well treated or maybe not treated as well in a different, just depending on what kind of facility they're at. They are, I mean, some people respond better for treatment, like for the medications for positive symptoms, they work fairly well on positive symptoms. There's not medications for negative symptoms. The antipsychotic medications are for the positive symptoms. So those can diminish, but the negative symptoms remain. So,
man.
Yeah. So
interesting.
Yeah, and so visual hallucinations, you see people, animals, flashes of light. Auditory are the most common, but visual are the second most common. Now there's also tactile, where you feel like maybe bugs are crawling on you, things of that nature. There's gustatory, which is a metallic taste in your mouth. And then there's olfactory, which you smell like bad smells that no one else can smell.
So my question, because like a lot of the things that we've talked with you about before and other things that we've talked about here, it has been, hey, this is tough or this is what happens, but there's um
Hi, everyone. I'm Allie Bailey, and now a quick word from us.
Howie Mandel here. Do you ever feel like you're just another ticket in a long line, especially when you're looking for help with something as personal as your own mental health? Lamco Wellness is bringing the human connection back to mental health care. It starts with a personalized intake process where they get to know you. They offer medication management that's actually managed, coordinating with you and your clinician to make sure you're both empowered and on the right track. It comes down to three things: personal connection, compassion, and absolute privacy. Stop being another number and head over to lamcowellness.com to take the first step.
All right, everybody. Now let's get back to the podcast.
there's moving on, there's treatment, there's management and everything. And I'll be honest, what you're describing to me, I'm just like, holy, this would be overwhelming. Like,
Yeah.
what does life look like? Is there a normal life with schizophrenia?
Well, many times as a person gets older, and depending what kind of care if they can live at home with people who really care for them, or if they're in some kind of institution, what their background was like to make, what was like their predisposition plus risk factors, all are variables that go into like determining what kind of life someone can have with this disorder. I knew someone who was one of 8 kids. One of them had schizophrenia. No one else in their family history ever had it. And he was able to do basic like janitorial work at their dad's company, but had to live in a group home. Because they want people, like they can get agitated sometimes. There's different behavior, like that we call like disorganized behavior is like maybe they get really agitated, or they, respond to people in an inappropriate way, or they like laugh at things when you're supposed to, when someone tells them a sad thing, but they laugh hysterically. They have like reversed emotion to like content. They will have, we call it echolalia, and that's when they repeat everything someone says. There's also a thing called clanging, where they rhyme everything. They just choose their sentences that will rhyme. Like there's at least a couple of words in each sentence that rhyme.
Okay, that's pretty cool. Like, you've been horrifying me for the past like 5-10 minutes, but
Yeah.
that would be pretty cool. I like that. That one I kind of like.
You have to take it positive. No, and then they also have something called word salad with disorganized speech, where they just come up with words. Well, there's neologisms when they come up with words that don't exist. But then word salad is when they it's all like garbled words together, and they have like loose associations between topics, and they'll be like, oh, so I was going to the train today. Oh, train, did you see, I was trained to do this when I was little. And they just go from topic to topic, and it's very tangential and very loose associations about their next sentence. And they call that word salad.
With that, I'm sorry, I keep interrupting, but I'm so fascinated by this, because a lot of the things we talk about, I have some knowledge of, zero knowledge of this. This is completely new to me. And I'm just so interested. So, like, when you're talking about the word salad, and we talked about this before in another episode, but like when I was younger, I was diagnosed with ADHD and some form of dyslexia, and that's kind of how my brain worked when I was younger. Is like things would arrive out of order, and they would be connected in a very disordered fashion.
Right.
Is that, how does the word salad for schizophrenia relate to something like the symptoms that I experienced?
Well, it's much more like severe than like just kind of having like people with ADHD, like myself, like you'll like your attention isn't always what it should be. So maybe you'll like catch something that someone's saying, and then when you respond, you use, maybe you have some loose associations, like things aren't totally connected because you didn't get like all of what they were saying due to attention and concentration problems. But this is just, I mean, when they talk, you're like, what? You're kind of confused by what they're saying. And then there's disorganized behavior where they act like they have like unpredictable behavior and sometimes could be aggressive, though it's not the norm to be aggressive. But they have like aimless, erratic, childlike movements when they have disorganized behavior. And those are positive symptoms as well, the disorganized speech and the disorganized thoughts. So those count as positive symptoms.
Okay.
So,
Okay. Now,
yeah.
I just wanted to jump in and ask a question because, and I appreciate you going more in depth of like what would be seen as well, I say on the clinical side, we would see what's positive and negative. I mean, I feel the person going through it might feel like not everything is positive and everything might be negative, but you earlier broke down a little bit more about hallucinations, right? And I would kind of categorize like a command hallucination to maybe feel more involuntary that the person's experiencing. And you started to also speak on delusions. So what comes up for me is, would you say that since a delusion is one's strong belief about something that's more voluntary, like they're experiencing that as a voluntary response versus it just being intrusive?
No, it's delusions are in connection with schizophrenia are false beliefs that strong false beliefs, like you said, that something is true when it is not. And an example would be, say, I've interviewed several people who think they're their own sovereign country, and therefore, like, they don't have to pay taxes, and because they're traveling, not driving, they don't have to have a driver's license because they're just traveling around. They're not driving. But the thing about delusional disorder that I think is really interesting is that you don't, unless you hit on the specific delusion, these people present as normal. Like until you get to whatever the specific delusion is, like maybe they have like delusions of grandeur, that they're this special, important, really famous person, or delusions of like religious persecution or paranoia, stuff like that. Paranoia about like certain situations, not globally. But if you hit on the delusion, then you're like, oh wow. But as soon as you're not talking about the delusion, they appear, like everyone else. So it just takes hitting on that to see really kind of the how it's not true and how they really, really, really believe that it is, and they'll defend it, to the end of time. So
Thank you.
yeah. Oh, no problem. So I'm going to talk a little bit about schizophrenia versus bipolar disorder with psychotic features, because this can be hard. There's two differential diagnosis ones that are really hard to decide which one is which. The first one is bipolar disorder with psychotic features. The second one is schizoaffective disorder. So the main difference is that schizophrenia is defined by psychosis and other symptoms like that we just went over, like the disorganized thinking, behavior, hallucinations, stuff like that. But definitely by the hallucinations and delusions. So, but bipolar disorder with psychotic features the central part of that is a mood disorder. While there could be some mood symptoms with schizophrenia, they're not prevalent. While with bipolar disorder with psychotic features, it is all about the mood swings. And then sometimes when someone has a really severe mania, that's when they could have some episodic psychosis symptoms. But that's not across the board. While with schizophrenia, it's across the board. But with bipolar disorder with psychotic features, it's every once in a while in the crux of a manic episode. So they both start in late adolescence or early adulthood, so they have that in common. So the negative symptoms of schizophrenia are in stark contrast to if someone's in a manic episode and they're like have high energy, their facial expressions are like, broad ranging. They have They engage in like dangerous activity or risky activity that, like sexual promiscuity, gambling, shopping without having the money to shop, like $20,000 shopping, not just like $50. So those are very different presentations. And then, they can have hallucination, but again, it's just for a very limited time when they're manic. So, and then they're treated differently. Schizophrenia is treated by antipsychotics primarily, and bipolar disorder with psychotic features is antipsychotics plus a mood stabilizer. So there's a little bit of difference there. And I'm going to go into the different like antipsychotics in a little bit. That's the difference between those. Then schizophrenia or schizoaffective disorder. Schizoaffective disorder includes mood symptoms, very prevalent mood symptoms with the psychotic symptoms, but there has to be a period, it's very hard to diagnose. There has to be a period where they're psychotic, but they have 2 weeks without any prominent mood symptoms. So it takes really good notes. If you're just meeting someone who has schizoaffective disorder and you're going through their records, to say like, oh yeah, maybe I agree with this diagnosis, they have to have really, really good notes of when they experience no mood symptoms and psychotic symptoms, and then both. Some people think it's kind of like a catch-all for like, oh, they have these symptoms, maybe mood, and I don't know what to diagnose them with, whether it's bipolar with psychotic features or this or that. So I'll do schizoaffective.
I feel like I said earlier, the symptoms that you're describing to me are what we used to call just crazy. And like I can see not just the temptation, but the tendency to look at, oh my gosh, there's this overwhelming amount of things going on, and just
There
being
is.
like,
Very
this
complex.
is our catch-all for overwhelming.
Right. Yeah. And I mean, when someone has, they're having auditory hallucinations, like a lot of times you'll see them talking back to the hallucinations, engaging in conversation with something that, obviously we can't hear, but they can hear. So they'll have like a running, dialogue with them. And it's really scary. I mean, people will say like, it's really scary to think that someone can be telling you, go kill yourself, go kill someone else. And it's also obviously distracting to have this voice, running commentary in your head all the time. Like, it's just overwhelming. And then there's also presence hallucinations, which I forgot to mention. And those are when you think someone is in the room with you, either standing behind you or like hiding. And those are really scary to patients because that would be scary to think there's someone in your house and you can't see them. Like they're hiding behind the curtains, and then, people get paranoid. There is paranoid schizophrenia. That's one of the types. And there's catatonic schizophrenia, which is like no movement. You just might be like rock back and forth, but you you just sit. You do not move other than that. You don't engage, you don't talk to people. You just do that rocking motion. Well, obviously paranoia schizophrenia is when you think someone's out to get you. Funny quote is people are like, well, what if it's true? What if they are out to get you? But they are not in this case typically. And people are, hyper vigilant and, don't go a lot of places because they're like, someone's going to follow me there. Then once they get me, they're going to do this to me. And it's would be really
Absolutely terrifying to me.
I think it would be totally terrifying, especially if someone's telling you to do something to someone else or yourself and you obey most of what they say for you to do. But a lot of people with schizophrenia that I've spoken to, like my patients, have said, I don't want to do it. They're telling me to do this, but I don't want to do it. But I followed other things they said. So I don't know if I don't do it, what's going to happen to me.
I mean, also from my perspective, like I know that there's been like sociological studies where if you say something to somebody often enough, they start to believe it. Like
Right.
if Like if somebody's constantly telling somebody I'm around to kill somebody, like this may be me being a jerk, but I kind of don't feel like it. I don't want to be around that person because I feel like eventually you're going to cave. Like eventually you're going to
Yeah, I mean, and they aren't people with schizophrenia typically aren't dangerous per se. I mean, they have sometimes aggression, but it's pretty random. Like unless they are a baseline aggressive person, like maybe before they even got diagnosed, then it's probably unlikely that they're going to be aggressive and hurt someone. But it happens. If they're really agitated and can't calm down, and that this person just tends to like walk into their delusion and be like the wrong time at the wrong place while they're being aggressive, then yeah, there could be some violence. It's not typical though. And it's a lot of people are like think schizophrenia is like multiple personalities, and that is not the case at all. That's a totally different disorder.
Okay.
They're now called
So, like not at all related.
Yeah. I think that's the biggest mistake that people make with schizophrenia is they think it's multiple personalities.
So I have a question real quick. Now, I understand that in some roles, like we might be able to get workplace accommodations if we have anxiety or depression. But what would that look like for someone that's been diagnosed with schizophrenia? Are there any accommodations that could be put in place to help them with their occupation or their schooling?
Well, I mean, a lot of them live in group homes. So they can really you try to show them like how to still have like good self-care, and maybe teach them rudimentary math or other things. I mean, it just depends a little bit like what their education was before they were diagnosed, and kind of what their baseline knowledge of things has been. I mean, some people who are like obviously like catatonic or grossly disorganized behavior, the main goal with them is just to like keep them safe, keep other people safe from them, and keep them safe from other people because they're very vulnerable. If you're catatonic, you're in a very vulnerable position. So
like there's no instance of schizophrenia that does not require some form of caretaker.
No, I mean, everyone I've met has either lived in like a institution, like an inpatient facility at a hospital or something, or in a group home. I knew one couple, and they both had schizophrenia and were married, and they had their own apartment. And I did this volunteer program where I tried to help them like learn how to take the bus, or just kind of everyday behaviors that we take for granted. And it was really hard because the husband was paranoid schizophrenic and the woman was not, but still she had schizophrenia. So it was hard to get them out and like to use the bus. And then they were really scared to use it the first time without me. And we wrote it over and over and over. And then as like, for like a reward, we'd go and get like, sodas and like a snack or something. But it was, I went into they weren't answering the phone. So I went to their house once, and it was just a disaster inside, complete disaster. I don't know how they were still living there, but, so that was one experience I had with them.
I always like to bring up this question in terms of like geographically. Any idea, or do you have any data where like which country has the most like number of cases with schizophrenia, or like if there's any race that's prominent to be diagnosed?
Well, there are people. Research suggests that if you were born in winter and early spring, you're more prone to be diagnosed with schizophrenia. If you have already you're predisposed and have the risk factors, then if you also have that you were born then, you're more likely to be predisposed to it. Also, if you use heavy cannabis use as an adolescent is a major risk for developing schizophrenia. And so whenever I work with adolescents, I'd be like, please don't, for many reasons, but it can lead to not just like, what they say, gateway drugs or whatever you think about that. But, it's could lead to
Well,
very serious mental illness.
to I guess defend weed, um, could that have something to do with that for a very long time, when it was illegal, it would be laced with substances like LSD?
Yeah.
Um, might that kind of inform those study results, or is that like, no, there was better controls on that?
If that was the case, then potentially, absolutely. But
Okay.
I don't know when these studies came out that said that,
Okay.
how old they are. I just know that research has said it repeatedly, but I'd have to look up and see like when the first studies that found that were when they came out. There's also, in terms of differential diagnosis, there's also schizophreniform and then brief psychotic disorders, which are schizophreniform. It has to be less than 1 month, and actually same, and it has all the symptoms of schizophrenia, but it's just shorter. Well, brief psychotic episode or disorder is some of the symptoms, but from 1 day to a month. That's the difference there. You don't have to have all the symptoms. You just have to have like the positive symptoms. You don't have to have the negative symptoms. So, and then I touched on delusional schizotypal personality disorder can also sometimes be confused with schizophrenia. It has subthreshold positive and negative symptoms, but it's marked by like really odd beliefs, social anxiety, very eccentric behavior, without the chronic intense psychosis. So like you don't see schizotypal people very much in therapy because they don't want to like leave their house and go there, or they just they keep to themselves. And, maybe I met one person who had this disorder out of the last like 20 years of doing therapy, and they would always wear like tinfoil on their head to reflect like messages that might be coming in to them. So they were always wearing that tinfoil. So they're like, I don't want to go out because people point and laugh at me, but they're like, I have to wear it. People don't understand that I have to wear it.
Like that behavior that you're describing, I'm like, oh, I've met a few people with that where they're like functional, but like there's things.
Yeah, they're like outliers kind of. And it's a personality disorder as well. So it's not a psychotic disorder. It's not a mood disorder. It's a personality disorder at its heart. But
I'm sorry, I'm going to keep interrupting you. I apologize for it, but just like,
it's for you to learn. It's for everyone to learn. So yeah, ask away.
yeah, sorry. Like, I feel like usually I'm like, oh yeah, mental health is it's super important, and I evangelize on it, and like hearing about schizophrenia, I'm just like, oh my gosh, I am genuinely overwhelmed by how much, like, what is schizophrenia? Like, this is, sorry,
Well,
keep going.
they have 50% of people with schizophrenia have substance use disorders. That's problematic for many reasons. I mean, it is with anyone, but especially with people who have schizophrenia, because you're not supposed to drink on medication, especially antipsychotics. So if they're drinking and using drugs on them, that's bad. And then it also causes them to go off their medication more frequently because maybe they're on like a bender and they forget to take their meds, or they lose their meds because they are out, whatever they're doing, out on the street getting drunk or doing drugs. People with schizophrenia also smoke like chimneys, which is really bad for their brains. Research has shown. Also, it's bad for your lungs, your overall physical, your physical problems. Like, and when I worked in an inpatient unit, they were allowed to go to like right outside the door and smoke, and they would be out there all day just chain smoking. So that leads to higher mortality risks, as to the cardiovascular problems. Like there's increased prevalence of heart problems, high blood pressure, high cholesterol. Then they'll develop like metabolic disorders like obesity, type 2 diabetes, things like that. They're more prone to get anemia and tuberculosis, and have thyroid problems as well. So they have a lot of physical problems that go along with schizophrenia. And there's a polygenic risk, and which means just that there's a lot of complex interplay between many genes. There's not one single gene that causes it. And so then there's familial risk, which is interesting because 1% of the general population will have schizophrenia. First degree relatives, if you have one parent who has schizophrenia, the risk for a child is 10 to 15% to develop it. Then if both parents have it, the risk goes up to 40% for the child to have it. Then this is interesting. Identical twins, even with identical genes, the risk for an identical twin with someone who has schizophrenia is 48%. And that shows that genes are not the sole determinant. There's also environmental factors as well, because they have identical genes and only one's getting it.
This is a lot. This is so much. There's so many questions, and wow. So first, when you said 1%, that's 1% to have the recessive gene that can lead to schizophrenia.
Yeah, the life
a recessive gene.
1% for people in the general population.
Okay, because I was like, you're lying. There's no way 1% of the population has schizophrenia. That's how I heard it the first time, and I was like, no. So that makes more sense. Thank you for clarifying that for me.
Yeah, right.
And then the identical twin thing, like,
that's fascinating.
Can we get some research on this? Because that just blows my mind that we can have identical twins where it doesn't manifest. Like, I feel like that just opens up a whole new range of things that we should be studying, because it's like conclusive proof there are environmental factors that lead to psychological problems. Like, full stop. It's right there.
Yeah, there's tons of research on it, and there's also, like, if you live in like an urban area, if you have low SES, socioeconomic status, if you're a migrant, if you've been abused, you have trauma background. There are so many factors that make you like predisposed to developing it when you add in like the genetic part. And then, like, if you have a substance use problem and you're doing amphetamines or something along those lines, that can trigger, because for, I think, kind of obvious reasons, because you're not, it triggers them, because it can make people paranoid even if they don't have schizophrenia, or all the other symptoms that might go along with long-time use of using amphetamines. And one of studies have identified neurotransmitter systems like the dopamine and serotonin that are involved with schizophrenia. So if those antipsychotics stop dopamine from coming through your brain the way that it's supposed to, or in a way that's negative. But I mean, the bottom line is it's not 100% heritable. Like I said, I had that friend, one of 8, his brother got it, and no one else had it. No grandparents, no parents, no one else, and none of the other children. So, and the life expectancy of people with schizophrenia is 61 to 71. However, if you have some of these cardiovascular problems, it increases not only your hospitalizations, but it increases your risk of, over 20 years, it increases your risk of dying from like cardiovascular problems and stuff to 86%. So if you have these other comorbid problems, then your risk to die early just increases like a ton.
61 to 70 is.
Yeah. Well, I mean, there's
that blows my mind.
cardiovascular problems. They're not practicing probably really good self-care. They might not be out like they're not out like doing yoga or at the gym.
Not imagine living that long if I had that, like, I feel
Yeah.
like I would struggle so much to do anything at all.
Be like in your 50s. But yeah, it's a little higher. Not, I mean, I think the average life expectancy of like a white male is what, like 76 or something, and white female is pretty close to that, maybe a year longer or something. Yeah, life expectancies are overall lower for like the African American community, and I think for the Hispanic community as well. So, but yeah, environmental factors linked to it include like birth complications like low birth weight, unexpected C-sections, complications from birth, and then like if the mom had an infection while she was pregnant, again, trauma, abuse, migrants are at bigger risk to develop schizophrenia as well. And overall, just maternal health is very important. And also, if the dad is older, that also increases the risk of a child potentially developing schizophrenia. Hearing impairment can be a risk factor. I mean, there's like so many things can be a risk factor. That's amazing that more people don't have it, actually, is what I think. But okay, so I know we have 15 minutes left. Let me see. So poor nutrition and lack of like vitamin D overall with people who have schizophrenia is not helpful. A lot of times they're not eating the healthiest food. They're eating like a lot of junk, especially if they're like in institutions, like vending machines are their friends. And the food in those places isn't like exactly like really nutritionally balanced and like, light and healthy. It doesn't tend to be anyway. I'm sure there's some places where it is, but generalization, it's not. So yeah, the lifetime prevalence is approximately 0.3% to 0.7%. And there's no differences between the sexes. So, prognosis is influenced by both duration and frequency of the psychotic episodes. Sometimes what we call someone will, and you can get it like abruptly like this, or you can have like more insidious factors, like what we call them prodromal symptoms. Like you start to have social withdrawal, like you aren't keeping up with your hygiene, your work or school performance just tanks. Maybe you have like maybe one psychotic episode, but maybe people don't really recognize unless, that's what's going on. And then then you won't have those symptoms for a while. And then you'll have like, boom, like a major, I don't say outbreak, but the symptoms come back more severely and then are chronic. So it's such a serious diagnosis. It's one of the few diagnoses that we call severe mental illnesses. Like we don't call generalized anxiety disorder severe mental illness, but like this we do. It falls into another category because it's so serious. So yeah, they also 5 to 6% of individuals with schizophrenia die by suicide. And then 20% attempt suicide, and then many more just have suicidal ideation, but don't act on ideations.
Yeah. Wow.
Yeah. And then I just wanted to touch briefly on medications. Schizophrenia is primarily treated with antipsychotic medications, and they're divided into two categories. There's older, which we call typical antipsychotics, and that's like Haldol and Thorazine, like what you think of like in the old movies, like where people are just like kind of sitting there drooling on themselves. And that's the days like when Haldol was really used like a lot and over medicated even, a lot of these people were over medicated if they were in facilities. And then the newer atypical antipsychotics manage the symptoms of like hallucinations and delusions much better than the first generation typical ones. And example of the atypical medications are like Zyprexa, Seroquel, olanzapine, Abilify, Risperdal. You might recognize some of those names, but they also have potentially fewer motor side effects. Like maybe you won't get tardive dyskinesia. You're not as high as risk to get that with these atypical ones, the second generation ones. Or if you do, it's less, they're a little bit less serious or less severe symptoms. Other common side effects are weight gain, which happens so much of the time. And another reason people don't like to take them. Metabolic changes, drowsiness, dizziness, dry mouth, blurred vision. And all psychotropic medications have some side effects that, at least they have to list, there's these 20 side effects you can get. And maybe, because someone somewhere had that side effect, so they have to list it. But with these, pretty much everyone has some of those side effects. So, people don't like the side effects, and, they don't want to take their meds anyway, maybe. And this is just more motivation for them not to take it. Yeah. So,
And it gets worse when that happens. Sorry.
Yeah. Yeah. And like I said, that every time someone goes off their meds and do it for longer and longer and longer times each time, it's just worse for the brain and is a worse prognosis for them the more often that they do that. So I tried to go fast, so I think but yeah, if you have any questions, take them.
So I'm just overwhelmed by this because you're like you've laid out some pretty severe symptoms, and then there's medication. All the medication has side effects, and then you're usually diagnosed with this in your adolescence. When I was a teenager, I could not stick to a medication schedule for the life of me. And I also didn't want to stick to a medication schedule for the life of me, just being a rebellious teenager. Like, would it be, because of that, would it almost be better to let them get through the teenage years and into, young adulthood before you start medicating them? Because, like, this is going to sound terrible, but I would not trust a schizophrenic teenager to consistently take medication that they need to be consistent on. I don't know.
Yeah, and that's a good consideration. That's a well-placed concern. So there are oral medications, and then there are long-acting injections that we call like for Haldo, it's called Haldo-Dec, and it lasts for like several months at least. They're like some of the medications can have effects on you where you have to have like regular blood tests to monitor like if you're getting high cholesterol, you're getting other metabolic problems, like you're heading towards obesity or type 2 diabetes. So for people who won't take their meds or can't remember, the injection is the better choice for them. And almost all the second generation antipsychotics have the injections as an option.
Hi, everyone. I'm Allie Bailey, and now a quick word from us.
Howie Mandel here. Do you ever feel like you're just another ticket in a long line, especially when you're looking for help with something as personal as your own mental health? Lamco Wellness is bringing the human connection back to mental health care. It starts with a personalized intake process where they get to know you. They offer medication management that's actually managed, coordinating with you and your clinician to make sure you're both empowered and on the right track. It comes down to three things: personal connection, compassion, and absolute privacy. Stop being another number and head over to lamcowellness.com to take the first step.
All right, everybody. Now let's get back to the podcast.
Right, that makes me feel a lot better. I know, I think, Allie, you wanted to ask a question.
Yeah. So, in addition to pharmacotherapy, I mean, what would be some common theoretical orientations a therapist might use, like DBT? I understand life skills might be a part of it, but what, in your professional opinion?
People, I think, would be using cognitive behavioral therapy more than DBT. I mean, DBT was, developed for borderline personality disorder, and then it's some of the aspects of it has, but like mindfulness is, a lot of people use mindfulness now, or some of the other aspects of DBT. But cognitive behavioral therapy would be used more frequently as well as like life skills training and stuff like that. But just and at I would say like a lower level, but a more basic level for the people who have schizophrenia, to teach them, you're not like showing them how to like battle dysfunctional thoughts because that might be a little above their comprehension. Um, it's not like it affects their IQ, but it affects their ability to like access information as easily as other people.
Just for the lay people, sorry, I didn't mean to interrupt, but just for the lay people like me, what is DBT?
DBT is dialectical behavioral therapy, and it was developed for borderline personality disorder, and for people who have like a lot of like, especially sexual trauma, but trauma in general. And that would be another great podcast because it's a personality disorder, and it's very interesting personality disorder, I think anyway. And it's somewhat been known not to be the easiest to treat, but it can be effective. DBT works if it's done correctly. You have to like go through all this training to become certified to do it. So yeah, I would say cognitive behavioral therapy would be the orientation that they would use. Any other questions?
I mean, I feel like I have 1,000 questions. I just can't organize my thoughts for a second to get any of them out because, like, that's all I got is just like so much. I could not imagine knowing someone who has this, being someone who has this, being a parent, a sibling
It
of
would be
someone who like
devastating
this
if
is
you had a child who had it, I think. Or, a sibling or whoever. It would be just devastating to find out that they had that and it, just completely alters their life in every way.
like I had a friend in high school whose older brother was profoundly autistic. And I remember like talking to her and she would just talk about how her entire life was shaped by her older brother because, like part of her life was caring for him and there was this expectation that she would continue caring for him after her parents were no longer able to, which is a lot to put on, a kid, but that's kind of how it goes. Um, and this is so much further. Like this is so much more. It's just overwhelming to think about that life.
Well, yeah, changes everyone's life who's involved in it. And like the friend I mentioned, that family was a very affluent family, so they could afford to put him in like really nice, safe group home. A lot of these individuals don't end up in group homes like that. And there's other like violent people in these group homes, and they're unable to defend themselves. Um, and
So
this kid who had it, my friend's brother, he died at age 55 from lung cancer because he smoked so much. And he, at the funeral, they had a picture of him like right before he was diagnosed, and like how active he was, because he was involved in. And then they had a picture of him, closer to before he died. Couldn't even recognize him as the same person. So I thought that was really powerful to see what it had done to him, physically, and how life as well.
So I have one last question before we wrap up, being cognizant of time. I remember reading years ago an article about how a lot of mental health institutions, when like they had somebody with schizophrenia, like a homeless person with schizophrenia, or a very severe mental health disorder, um, but there was nobody to pay for it, they would just put them on a bus to another city and kind of be like, not our problem anymore. Is that like, is that a common thing, or is that just like, hey, we heard about this and so we're reporting it?
Yeah, I haven't heard of that happening, but doesn't mean it didn't happen. I could see that happening if they're like in not a very good facility, or a facility that's struggling with funding, something like that. Most of the ones, people with schizophrenia that I came in contact with, were in inpatient units, like Department of Mental Health inpatient units. That's like when I was in Massachusetts, it's Department of Mental Health, and they would be in their inpatient facilities. And they're, for the long term, they weren't going anywhere. So sad.
Okay, that makes me feel a little bit better, because this was a lot. But thank you so much for coming on here and talking to us about schizophrenia. There's so much that I didn't know. I knew nothing about it. Um, I I wanted to ask you about like true or false different depictions of it in media, but I've already gotten that all the depictions that I know of are wrong. So
Yeah.
uh, uh, so thank you for kind of uh, educating me and
Oh, you're
hopefully
welcome.
everybody else
I
who's
hope
watching
you
this.
learned a lot.
Uh,
So good.
yeah, and thank you again to Ali and Ravi.
Yeah.
This is the Better You podcast. Don't forget to like and subscribe. Um, Thanks again. See you next time.